Today I'd like to discuss myasthenia gravis. Myasthenia gravis is an autoimmune disorder of the neuromuscular junction, characterized clinically by muscle weakness and fatigue. Immune dysregulation plays a key role in the pathogenesis of myasthenia gravis. Autoreactive T cells develop in the thymus, which display a strong affinity for muscle end plate proteins, such as nicotinic acetylcholine receptors, muscle-specific kinase, or lipoprotein receptor-related protein 4. These autoreactive T cells evade inactivation by central thymic mechanisms that typically ensure self-tolerance. Upon escaping to the periphery, the autoreactive T cells bypass suppression by Tregs and other cells that maintain peripheral self-tolerance. This process leads to the activation of B cells, culminating in the production of pathogenic autoantibodies. About 85% of patients with myasthenia gravis produce acetylcholine receptor autoantibodies. A subset produce autoantibodies to MuSK or LRP4. A small percentage, around 6%, are deemed seronegative. The final common pathway appears to be the destruction of acetylcholine receptors and reduced density. The thymus is important. Most patients with acetylcholine receptor positive myasthenia have thymic abnormalities. Around 60 to 70% have thymic hyperplasia, 10 to 12% thymoma. Thymic inflammation, development of antibody-producing centers likely contributes to the loss of tolerance. Signs and symptoms. Myasthenia typically manifests in two forms, ocular and generalized. Those patients with ocular myasthenia symptoms, such as eyelid drooping or double vision. Generalized myasthenia may be associated with a variable number of other symptoms, such as dysphagia, dysarthria, facial weakness, head drop, limb weakness, dyspnea, or respiratory failure. The Myasthenia Gravis Foundation of America has published a widely used system to classify the severity. In brief, there's Class 1, isolated ocular muscle weakness. Class 2, mild generalized weakness involving non-ocular muscles. Class 3, moderate generalized weakness. Class 4, severe. Class 5, respiratory failure. So what are the effects of myasthenia gravis on movement control? In all muscle groups implicated, the disruption of control occurs at the level of neuromuscular signaling. In myasthenia gravis, the presynaptic neuron is thought to be preserved, and the release of acetylcholine molecules continues. Conversely, there's a widespread reduction of acetylcholine receptor density and damage to the muscle end plate. So consequently, only a small population of functional receptors are available for acetylcholine binding. As a result, there is a decrease in the size of the postsynaptic potential signal for muscle contraction. This weakness becomes more pronounced with repeated use because it depletes the acetylcholine store in the neuromuscular junction. Thus, in a situation where limited acetylcholine binding is possible and there's a reduction of acetylcholine quanta, this can result in subthreshold postsynaptic potentials that do not generate action potentials in muscle fibers. Accordingly, muscle weakness ensues. There are four main options for medical treatment. Symptomatic treatment with acetylcholine esterase inhibitors can be sufficient for patients with mild disease. This class of drugs can be used in almost all subgroups of myasthenia gravis except those with anti-MuSK antibodies. Chronic immunotherapies target the underlying immune dysregulation. All patients with myasthenia can be treated with this regimen. Immunomodulating treatments include plasma exchange and IVIG. These are suitable for all subtypes of myasthenia, but are reserved for severe exacerbations, such as myasthenic crisis with respiratory failure. Surgical treatment, specifically thymectomy, is generally indicated for myasthenia gravis patients with thymoma or those aged less than 50 years who show anti-acetylcholine receptor antibodies and generalized disease. The role of exercise therapy in myasthenia gravis is currently being investigated. So far, only a limited number of small sample brief intervention studies have been published, and some of these lack controls. The two main types of intervention are respiratory and general physical training. Respiratory training has shown some promise for those with moderate to severe myasthenia and could be helpful for managing symptoms such as fatigue, dyspnea, and even respiratory failure. Likewise, physical training, which includes whole body aerobic and/or resistance exercise, can be effective in improving limb muscle strength and aerobic capacity in patients such as those with mild to moderate myasthenia. A standout study is the randomized control trial recently published by Misra. They found that 30-minute daily walking program for 12 weeks improved the 6-minute walk test distance and rating of quality of life in their small sample of myasthenia gravis patients. So in summary, strategies that aim to improve muscle function are likely to be beneficial. Efficacy of exercise for managing myasthenia is a promising avenue for future research. Thank you.